Hello all, I'm Brent Siegel, a senior in global health, and infectious disease fascinates me. Specifically, the stigma and spread of HIV in our own backyard, Tijuana. For both Mexico and the United States, it is a costly disease to treat, and it is costly socially for those that acquire it. Between San Diego and Tijuana, 60% of the population is mobile, and genetic studies demonstrate a high degree of cross-border transmission. Fortunately, a silver bullet does exist. Antiretrovirals, or ARVs, are a key component in mitigating the progression of HIV to AIDS. Furthermore, sustained ARV use ensures that one cannot transmit HIV to others. Mexico has purchasing contracts as well as access to these ARVs. Additionally, healthcare in Mexico is free and covered by one of the many social security programs the government offers. In Mexico City, there's even a plaque which commemorates Mexico's achievement of providing healthcare for all. This should include ARVs. Despite this, the HIV microepidemic grows daily among men who have sex with men, injection drug users, male to female and female to male persons, as well as sex workers within Tijuana. It is estimated that only 3.7% of these individuals are retained on ARVs, and only 11% know their HIV status, even when testing is purportedly free. Why does this growth occur, despite the resources purportedly available to them? In my non-systematic literature review, I consult the sparse medical as well as widely available anthropological literature concerning historical, social, and cultural barriers to care these persons within Tijuana face. While most research done looks at each of these risk groups within Tijuana as isolated entities, large between-group transmission rates suggest that more research must focus on the shared risk factors and barriers to care between groups, as well as the ways in which risk group status may change or not be as fixed as studies make them out to be. In my study, I find both social and cultural factors which are likely pervasive among many risk groups. Additionally, I find so much heterogeneity of populations within the injection drug user and sex worker risk groups, I call into question the validity of using these terms to describe discrete risk groups at all. For example, the injection drug use group, which is normally considered a singular risk group with singular risks, is comprised of a large proportion of male to female and female to male persons, as well as men who have sex with men, and even sex workers. While injection drug users are comprised of both male to female persons and MSM, the HIV risk factors which drive both of these more discrete risk groups to injection drug use, as well as the risk factors which bar men who have sex with men and male to female persons from acquiring HIV medication, are wholly different. For example, MSM may be driven to drug use as well as sex work on the basis of cultural machismo or machista values, which permeate gay culture within Mexico. On the other hand, male to female and female to male persons may be driven to injection drug use and sex work due to their unprotected legal status with the formal workplace. This is something men who have sex with men do not have to deal with. Consequently, the risk factor of groups who comprise IDU are not homogeneous, and using injection drug use as a singular group with discrete risk factors may cost sensitivity when describing the overall HIV crisis.